Hi guys, how's it going? I hope you had a great weekend. This is week number 2, and I hope the first week went well. But if you have any questions again about the syllabus or anything that we need to do for this course, anything that is expected from you, just let me know via email or by logging on during our virtual office hours. Since I mentioned office hours, I want to make a small announcement about the small change. So usually we have office hours tomorrow, Tuesday, but there's a conflict. I'm presenting at a conference. Therefore, I am moving the office hours to Wednesday. So not Tuesday, but Wednesday, same hours from 8 in the morning until 12:30 Eastern Standard Time. That's one thing I wanted for sure to remember. I have my notes here. Uh, what else are we gonna do today? I'm gonna give you some feedback concerning what you submitted until last night. I'm gonna present two chapters, chapters 2 and chapters 3, and also, of course, I'm gonna remind you what you need to submit by Sunday midnight. All right. So I sent out um, the extra credit for the synchronous meeting for those of you who attended. And if you want to see when the next meetings are scheduled, please go to our Moodle site and start scrolling down, and you'll see when the next one is scheduled for. We have 6 in total, so there are 5 more left. Okay. Also send out the extra credit the extra credit for the ECLO. Sorry. So those 10 points, and you have been graded for your submission for LO1. On average, here I see that uh, the grade was pretty good, right, for just the first quiz. Uh, these quizzes are, LOs are from ACSM, so I'm not changing the language, I'm not changing the format, because I want you to get used to the way they are creating the items for their certification exam, right? So the average score was 89%. There was only one question that most of you did not answer correctly, and it had to do with CDC data concerning U.S. adults who are inactive, and the answer to that is in Figure 1.1, and that's the way I'm going to be giving you the answers to those items, those problematic items each time if we have any. So the answer is go to Figure 1.1, Chapter 1, 5th edition, our book from PED214. So go there and look at it, and there you'll find the correct answer for that item. Yeah. So I'll go pretty quickly and share our Moodle site. Hopefully, let me see what is going on here. Share. Here we go. All right. So for next week, so today I'm going to present chapter 2, which I was supposed to start last week, but I didn't feel like putting so much on you because it was the first week. And I'm also going to present chapter 3. I'm not going to start chapter 4. I'm going to start it next week. No big deal. Make sure you submit, make sure you know that you have to submit 5 LOs, right? This week. Sometimes you have more, sometimes you have less. Like next week you have 3, right? It depends on how many chapters we cover. Some chapters are longer, some chapters are shorter. Plus, at the same time, we go back to the PED212 book, right? The 5th edition of the personal trainer resources. So you have 5, LO 2, 3, 4, 5, and 6 due on Sunday. So by Sunday midnight, please do not forget to submit those 5 LOs. I'm gonna stop sharing this, and I'm gonna start sharing the first slideshow for today, which is chapter 2. Very important chapter. So I hope you can see it. So here we're talking about pre-participation health screening. In the first chapter that we covered last week, we talked mainly and mostly about the benefits and risks of exercise. We talked about what is physical activity, what is exercise, what is physical fitness, and the components, the health-related and the skill-related. Those were the most important things. Now, you as a trainer, as a coach, you need to screen your potential clients, patients, trainees, before you start working with them, okay? And this is what we're going to talk about today. In this 10th edition, there was a very important, significant change compared to the 9th edition that we're going to talk about. So before this, the book before this, the guidelines were different, very different, I would say. So I want you to pay attention. There's a thing called the algorithm. We covered it last semester, right? So now I want to make sure that's one thing you are focusing on from this specific chapter. You need to know the algorithm, and you need to know how to apply the algorithm. In both chapters 2 and 3, they have case studies. So use those case studies to make sure you know how to apply what we're going to talk about today. And more specifically for chapter 2, you take the algorithm, right? You go to those case studies, and you're trying to figure out, you're trying to answer correctly. If the answers are in the book. If you don't, make sure you go back to the algorithm and figure out why you made a mistake and learn from it, okay? Because that's the way they're gonna assess your knowledge during that official certification exam. We're gonna give you a scenario, we're gonna give you several questions about it. One could be something similar to those case studies that you need to use the algorithm. All right, so this is working. All right, okay. So, as I said before, the previous edition, the 9th edition of this book, the GETP 9th edition, was different. There was a thing there called risk stratification. So you would take your patient or client, you have a list that we're going to talk about today, and then you would classify them based on, you would group them based on a risk classification. So it would be low risk, moderate risk, or high risk of a cardiovascular event, or high risk patient in general. So based on that classification, you will refer them or not. Okay. That was a great way to do it. However, unfortunately, it was we ended up referring more patients than we anticipated. So in a way, although we're like, oh, we need to exercise is medicine, so we're pro-exercise, we ended up referring all these clients to specialists. So in a way, again, we were creating obstacles. So instead of facilitating people and help them exercise while they were coming to us to exercise, we refer them and then keep referring them, and in a way, we would discourage them to come back and exercise. So there was a round table. A lot of important people gathered. They went over all the current evidence at that point, and they came out with the new guidelines. So the new guidelines do not have that risk stratification. So the CSM created that term, and ACSM are the ones who said, we're just not going to use it anymore. Okay. So also there are recommendations for physician clearance, general recommendations, not specific recommendations. So to make it again more like friendlier towards people who want to exercise. And also the pulmonary disease was not we won't now automatically refer them, right? Unless there are other uh, chronic conditions. However, just pulmonary disease, it's not a criterion that we will use to automatically refer individuals for medical clearance. Okay, that's really important. So there are three main things, and there are three main things slash questions that we ask now when we're doing this pre-participation screening. Okay, one has to do with the individual being physically active or not. One. Then we ask them if they have the symptoms, okay, as you will see, or if they have the chronic diseases, if they don't have the signs and the symptoms. And then it moves to the end of the algorithm, as we say, and then we give them the intensity. It can be high intensity, vigorous intensity, or moderate intensity, or light intensity. We talked about this before, but we're going to see it again. And this is something I need you to know from this chapter. This is very important. Now, I'm going to go here. I'm going to come back. I hope you remember this, right? There are a lot of notes at the bottom, but the basic here, the basic information that you need to remember is, are you physically active or not? And mainly we're talking about cardiorespiratory exercise. And you know which are the guidelines, right? You know which are the minimum requirements. So if somebody has met the requirements for the past 3 months, that's a yes. That's the very first question. If they said no, of course, if they haven't met, that's a no. And then we have this and this, which is for those reasons, right? It's the same thing, but it's with a yes or no. And then we talk about signs and symptoms that we're going to explain. And then we'll talk about if you actually have that. And then based on that, we refer them for medical clearance or not. And we also give them intensity if we can. That's the algorithm. We talked about it before, and it's in our book in the 5th edition that we have in PED214. This is important. This is very important, huge change in this edition of the GTP, and you get a lot of questions based on that. And it's really important to know because you will actually use it. So I'm going to go over again the signs and symptoms that we talked about. I want to make sure you understand that we're talking now about cardiovascular, metabolic, and renal disease. Do you remember which organ is associated with renal disease? Is it kidney? All right, so which are those signs? First of all, we have pain, right? Pain or discomfort. And there are way more details in your book. You can go ahead and read them and make sure you understand. The basic idea is here that they result from ischemia. What is ischemia? We have some restriction of blood flow, right? That's why we have that pain. Shortness of breath at rest or mild exertion. Should we have shortness of breath at high levels of exertion? Yes, but when we are at rest, we shouldn't have shortness of breath. So that's an indication, that's a sign or a symptom, right? Or maybe of something, of a disease or condition. So we should look into that. Dizziness or syncope, which is that loss of consciousness, right? And maybe again associated with some kind of ischemia. We should look into that. Orthopnea. What is orthopnea? It's again like shortness of breath, like dyspnea. That's what this dyspnea is, right? but it's a specific type. So when you're laying down recumbent position, that's when you get it. And then when you are sitting or standing, then it goes away. Paroxysmal nocturnal dyspnea, of course, has to do with the night, and you're sleeping 2 to 5 hours in. While you're sleeping, you have that dyspnea, difficulty to breathe, right? And it goes away once you sit on the side of the bed or you stand up. That is again an indication, maybe an indication of something bigger. Ankle edema. We can have unilateral, we can have bilateral, mostly seen at night. Bilateral, most likely bilateral is more serious than unilateral. Okay? Again, indication of something bigger. Palpitations, when you have that unpleasant feeling, you can feel your heartbeat, right? And it can be tachycardia, brachycardia, but it's unpleasant for sure, and you can feel it. It can even be anxiety, but it can also be something deeper than that. We should look into that. Intermittent claudication is that feeling that we have when it feels like sorry, this is working. It feels like, what's the word I'm looking for? We feel on our calves, mainly when we're walking, like especially uphill. Once we stop, it goes away, and it's like a burning feeling. What's the word I'm looking for? It'll come to me. That's intermittent claudication. Murmurs have to do, of course, with heart function, sometimes with valves, sounds that we can, maybe something, may not be something. And unusual fatigue, of course, we should feel fatigue when we're exercising really hard. But when we are not exercising really hard, if we are tired, or we get tired, or we get a shortness of breath, that may be an indication again that there's something deeper in there. We should look into it. So all these are major signs and symptoms, and we ask them if they have ever experienced them. Okay? What am I looking for intermittent claudication? I'll come to me. Sorry. All right. So at some point I'll be like, oh, this is what I was looking. Yeah, nothing really important here. Oh, it feels like a cramp. Oh, I told you. So again, the algorithm has to do with mostly I don't want to go there. So yeah, it's exactly what I was talking about, overly conservative. Okay, nothing really here. So in general, just as you see here, it's a two-stage process, right? And we use that algorithm to see if they can be cleared or not. If they're going to be referred, then it's more on the specialist who send them to, if that makes sense. So it's more on them. They're going to come back and they're going to have some kind of instructions of what they can and they cannot do. But that's how we use the algorithm now. We're not trying to create more obstacles, while at the same time we're trying to make sure that it is safe enough for them to participate in exercise. All right, so there are some tools that we can use. And there are some tools that we can give them, right? And there are some tools that they can use by themselves. Those tools that they can use by themselves, they're self-guided. They're called self-guided. So there's they're self-reporting. They're reporting themselves some information that we need. So on top of the algorithm, we have some other tools that we can use. A classic one that they can use by themselves is the PARQ Plus that you actually used. You had an LO specifically, right, to use the PARQ Plus. And we used to use PARQ. Now HCSM says no, we're using PARQ Plus. You already know what this is, right? Have the initial questions, and if you get a yes there, then you move on to the second and third and all the way to the fourth page, of course. We've been over this, so I'm not going to stay here. What do we have here? Oh yeah, the algorithm is mainly about cardiorespiratory exercise. It's not, as you see in the second dot, it's not about resistance training, because we don't know enough about complications of resistance training or not. So we don't have recommendations that have to do specifically with resistance training. And that's why when we ask them if they are physically active, it's mostly about cardiovascular exercise. Right? Remember, 150 minutes, 75 minutes, combinations, and that's for the past 3 months. We talked about this. We said that, of course, the very first question is if they're physically active, and then we go if they have diseases or the signs, and then we can identify the intensity. That's exactly what's going on here. And this is the other version to say no. Now, there are some other tools that we are, they're suggested to use them. That's for us. But this is something that we, as exercise professionals, will use. That it's not self-guided. They're not going to do themselves. Our clients, our trainees, our patients. Okay. So in this case, it's us that are using them. And of course, we went over this during PED214. It's nothing self-explanatory. If you read it, if you answer no, this question, you could go to the next one. If not, you go, and so on and so forth. This is the series certification that I was talking about. So just to make it clear, ACSM studied this, okay, with AHA. And then ACSM said, well, it looks like it's too much, so we're going to use the algorithm. However, other organizations still use it. Example, the AACVPR, right? And there, we said about the risk stratification, right? So I told you it would be low risk, moderate risk, and high risk. So high risk, of course, is the risk. And in the lowest risk here, you see the characteristics of patients, right? Absence of ventricular dysrhythmias. So the rhythm is not optimal. It's like you have a bad rhythm of the heart rate, okay? Angina, chest pain, remember? Absence of angina. Presence of normal hemodynamics. When you say hemo means blood. So here we're talking about dynamics of blood flow, right? So if I increase the intensity, what do you expect that my heart, what do you expect to see concerning my heart rate? Go up, right? That's normal hemodynamics. And you see the meds, they have ability to go 7 or above. That's the lowest risk, right? Your resting ejection fraction is, if you remember, how much, the quantity of blood you can eject by one beat. 50 or above, that's good. I don't know. It's goodish, and you are grouped in the lowest risk, right? Uncomplicated myocardial infarction. What's myocardial infarction? I hope you remember, right? Absence of complicated ventricular arrhythmias, arrest, absence of congestive heart failure, which is heart failure happens, it's over time. The heart kind of fills up with fluid and then it can function. It's a very simplistic way to say it. Ischemia, you remember that? Restriction of blood flow, right? And clinical depression. We're talking about clinical depression because we're not talking about depression that happened for a week or two because something happened in your life. We're talking about being diagnosed, right? There are specific signs and symptoms that psychiatrists will see and diagnose somebody with clinical depression has to do with DSM, right? Which is the Bible of the psychiatrists. Is the moderate. The highest risk here, you can see that we have presence before we'll talk about absence. So this is, of course, more serious situations. I'm not going to go into details. Presence of angina, you see high levels of silent ischemia. Silent ischemia is ischemia, but the person that has it doesn't really feel it. So it's very sneaky. That's why we call it silent ischemia. I'm going to talk about ST segment depression later on. We're not going to cover it right now, but and we covered a little bit in PED212. However, no, right now we have other chapters to go over that. Abnormal hemodynamics, as you can see, chronotropic incompetence. So your heart pretty much doesn't have the ability to function in a way that it is, how should I call it? Appropriate to, let's say, the stress it's going through. So again, if I increase the intensity and your heart rate or your systolic blood pressure drops, that's not good, right? That's definitely not good, and we should terminate exercise in most likely probably 5 minutes. Rest ejection fraction even lower. Nothing really. Same thing, just worse for the highest risk group. All right, and that's chapter 2. Again, we'll cover some things in PED212. If you have any questions, it's in the book. If it's not exactly in the book, look it up. Search. Don't. You need to be able to understand everything that's in the book, because the questions are going to be in the book. If you know the material, then when you take the exam, there are not going to be any hard questions, because everything, all of the questions are going to be from the materials that we are seeing or studying in those books. Okay. All right. So let me see. Let me go and find chapter 3 and go over that. Share screen. This one? Yes. I think so. All right, so here we're talking about pre-exercise evaluation. So the chapter that we just covered had to do with some exercise, pre-exercise health screening that we do. But once we refer them and they go to specialist, then they have to go through another kind of evaluation, and it's called pre-exercise evaluation. So that's what is this chapter about. This chapter is about, we have already screened them, and during that screening process, we saw that there's enough information to refer them. And so they're not now with us, they're with a specialist. And this is what a specialist will do or should do. That's exactly what we covered. All right, so we're going to go over some informed consent procedures, what kind of history they're asking, what kind of tests, what kind of physical tests and laboratory tests, and at the very, very end, what kind of instructions they should be aware of, the participants, before they participate or they take those they go through the actual examination. So in general, the healthier you are, the less you have to go through, and the more chronic disease you have, the more you have to go through. I hope it makes sense. The informed consent. The informed consent is very specific to the facility, it's very specific to the patient, it's very specific to the exercise tests that you're going to go, or the individual will go through. So it really depends on how it will actually look at the end. There is a form in the book and in this slideshow, so you can look at it. In general, you explain to them why they need to participate, why they were chosen to participate, risks and benefits, who's going to be in charge, who they can ask for more information if they want to, if they can stop at any point or not. Specific instruction about the test. What else? That's the kind of information that you include in the consent form. Yeah, free to withdraw with no penalties. If they're minors, then of course it's a little bit different. We need to ask the partner or the guardian. It's more complicated. HIPAA is important. It has to do, of course, with the information, the privacy. I've talked about confidentiality as well sometimes. What else? Yeah, if it's for diagnosis, should be stated. So there's a specific way to do it. Most likely, you are not, even if you are in a facility like that, you're not going to have to write the consent form, but you will have to know the consent form in case you need to read it to a participant if you're in a clinical setting. Medicine procedures, okay, all right. So this is a general information and an example. Now, when we talk about medical history, these are all the components. You see that it's pretty thorough. It goes from medical diagnosis all the way to family history. So a lot of information is in there. And all of this should be taken into account before the specialist makes their decision. Okay? Here are some risk factors that we specialist is going to look into that, right? And we use actually we used to use this table when the ACSM did the risk stratification. So this was a table. So we're going to look into this and pretty much count how many risk factors each individual will have. And then based on that number, we'll group them into lower, that medium kind of level and high level risk of client, right? And you see we have HDL, diabetes, dyslipidemia, obesity, all of that, right? Again, physical examination, you see body weight, you see pulse rate and rhythm. A lot of people don't understand the difference. A simple way to understand that is that rhythm is about the rhythm, right? Rate has to do more about the force of the rhythm. So rhythm is about arrhythmias, dysrhythmias, and so on and so forth. Okay. But the rate, a lot of times we're talking about weak heartbeat or strong heartbeat. That has to do more about the rate, if that makes sense. Of course, blood pressure, circulation of lungs, right? Stethoscope, and so on and so forth. All of this. The doctor will have to go through abdomen for bowel sounds and so on and so forth. Everything. All this is in the book, nothing too fancy. Those are laboratory tests. And you see that all individuals should have the very first two dots. That's classic. Now, if you have any signs and symptoms or actually the cardiovascular disease, you go through the second part. And if you have any kind of pulmonary disease, you go through the third one. Okay, so as we said before, the healthier you are, the less you're going to go through. The more chronic disease you have, the more you're going to go through. I go over them, make sure you understand what those tests are about. This is how you take blood pressure. We went over it in PED214. Usually when we're in class, we watch the video. You can watch the video online. We don't have a lab where we can actually practice, but this is how we do it. Those are the potential sources of error. Nothing really crazy here. You may get a question though, although you're not going to actually perform that. Just know that you have to have the proper cuff size, for example. That has happened to me. They changed the cuff size, they put a bigger one, and then my blood pressure, the the score that I got, the number was lower. Okay. All right, so here uh, we're talking about how do we classify and how do we manage people with uh, high blood pressure, depending on their blood pressure. And we've talked about hypertension, and we said that they call it the silent killer because a lot of times we don't even know that we have hypertension. However, it is associated with morbidity and mortality, very premature death. Okay, so you see that normal, I hope you remember, is below 120 and below 80. 120 and 80 is not normal, right? 120 up to 139 and 80 up to 89, you see, or, right? Either SBP or DBP in those ranges, that would put you in the pre-hypertension group. And if you don't have any other compelling indication, and you can see the compelling indications at the bottom, like coronary artery disease, heart disease, or diabetes, or chronic kidney disease, CKD, then, okay, yes, you should change your lifestyle, meaning, we'll talk about it in a little bit. Maybe you have to change alcohol consumption, definitely exercise, and definitely change your diet based on DASH. We're going to talk about that in a little bit, right? But no drugs, no meds. Now, if you are hypertension stage 1, definitely, again, lifestyle modification. If you have other conditions, yes, we have to include meds for hypertension as well. Now, if you are stage 2, even higher blood pressure, right? And you see again, it's or, either or, SBP 160 or above, or DBP 100 or above. Whether you have compelling indications or not, it doesn't matter. Now, definitely you're taking hypertensive drugs, and actually you may take more than one. Okay. And that was based on JNC, the Joint National Committee, the 7th report. Now there's out the 8th report. The 8th report is a little bit different, and it tells us to take action or not based on different criteria. For example, patients above or equal to 60 years old. So what you need to know from this is that a lot of people, there's JNC 7 out, and they're following JNC 7 out, but JNC 8 is out, and now we have started shifting the way we are addressing classification of pre-hypertension or hypertension in adults. Second dot is really important. We talked about that before. I kind of mentioned it like in PED214. I kind of mentioned it today too. The relationship between blood pressure and risk of cardiovascular events is continuous, consistent, and independent of other risk factors. Okay. All right. So when we talk about life modification, what do we mean? First of all, you see it's very important. We talk about physical activity, weight reduction, DASH, right? Which are the dietary modification that we need to do against hypertension, right? Excuse me, fruit, vegetables, low-fat products, and so on and so forth. And moderation of alcohol consumption. That's the lifestyle modification we're talking about when we were trying to describe what was going on with that table. This is something that we've talked about before again. It talks about cholesterol, total cholesterol, LDL, HDL, and triglycerides, right? Triglycerides all the way at the bottom. You see the normal numbers and ranges. You see the total cholesterol as well. And then I hope you remember that we want the LDL low. L stands for low. So we want it low. And the HDL, H stands for high. We want it high. So high HDL is good, and low HDL is low. Okay. All right. So these are, what are those? Okay. Yes. Selected blood variables. So here you see different kinds of variables that you can have in the ranges, the normal ranges, that have to do with blood work. I don't know if you have done any blood work. You see that in the beginning, those have to do with the amount of oxygen in your blood, and then the glucose, the HbA1c, of course, have to do with more. Diabetics are really interested in that, or pre-diabetics, because it has to do with that, or diabetes. Then you see creatinine, you see albumin. What else do we have there? And those have to do with what, as you understand? With your kidneys, right? And at the very bottom, you have AST and the rest, and those have to do with your liver. So this is, nobody will ask you to remember all this. At least if you can understand that AST has to do with liver, right? Then you can understand a little bit more if you, even if you see your own blood work. Pulmonary function. So testing is with spirometry is recommended for anybody, for all smokers above 45, and in anybody that presents dyspnea, shortness of breath. Remember, cough, chronic cough, wheezing is the sound when we hear through the stethoscope, and excessive mucus production. We have some measurements that we care about. All right. So we care about, first of all, for FVC, which is how much air can you breathe out with one breath. That says something. How much air can you breathe out in the very first second of one breath? That's FEV 1.0. That's important. And then we create the ratio. You see how we use the ratio in a little bit. And the peak expiratory flow has to do with the speed of the air. Okay. So we have the ratio. What I want to remember from this, at least the minimum of information, is I will have obstructive, right, and we'll have restrictive disorders. Obstructive have to do with what? In a very simplistic way to explain it, you can't breathe out the whole amount of air that you're trying to. That's if you have obstructive, such as asthma. Restrictive is you can expand as much as you would if you were healthy. So you need pulmonary fibrosis. Okay, so restrictive you can expand, and obstructive has to do with breathing out. You can't breathe out the whole amount of air. So when we talk about spirometry, we have different kinds of education. So the very first part of this table, you'll see that it can be used for diagnosis, monitoring, disability, all the way to public health, so we can create ranges for groups and sexes and so on and so forth. And then this is the second part that we use for to classify people. How severe is a COPD? So here you see, first of all, you have to have that ratio, the very first second over the whole amount of air that you bring out with one breath. In order to be in these kind of classifications, it has to be lower than 0.7. 0.7 and above, you go. So if it's lower, it's lower than 0.7, then you go and you see if the very first second is above or equal to 80% of predicted, the range that you should be in, right? If it's not, that's mild. And if you can go all the way down to less than 30%, which is very, very, very severe. Here we have the American Thoracic Society, ATS, and the European Respiratory Society. This is a classification, again, of severity based on just the very first second of that amount of air you're breathing out with one breath, expiration, right? In order to be in this one, you have to be definitely less than the lower limit of normal, LLN. So if you're in the less than the lower level of normal, but your FEV is equal or above 70, then you're mild, and you can go all the way to less than 35, which is very severe. And that's the last thing for today. it's different instructions that the participants should know, and it depends on the test. You see, if they can smoke, if they can eat food, or how much hydration, what kind of clothes, and the last one is kind of important because they may be taking medication, and sometimes we tell them to stop the medication, so we can actually get results that we can interpret. Sometimes they cannot stop the medication because it's a very serious condition and they cannot stop the medication. So they let them take the medication, go through the exam, that test, exercise test, and we take that into consideration, the fact that they're actually using some medication that may alter the results. I think that's all. Yes. So that's it, guys. Thanks for watching this whole thing. About 50 minutes, that's great. I'm trying to keep them below an hour, so I'm not too boring or I'm not using too much of your time. Make sure you study the book. Make sure you understand you have more LOs this time by Sunday, and that I move the office hours from tomorrow to Wednesday. So if I don't see you on Wednesday, you'll at least see me next Monday. All right? In the meantime, live intentionally, not habitually. Bye, guys.